My name is Sanjay Anchoso. I'm from the Catholic University, and I'm in the first cycle of medicine career. I'm going to speak about shortened antimicrobial treatment for acute otitis media in young children. Acute otitis media is an acute inflammation of the middle ear and may be caused by bacteria or viruses. A subtype of acute otitis media is acute suppurative otitis media, characterized by the presence of plaque in the middle ear in around 50%. The eardrum perforates.
Pathology of otitis media. When the eustachian tube is blocked due to allergy or infection in the upper part of the respiratory tract, fluid accumulates in the middle ear behind the eardrum. This causes an infection and the middle ear gets inflamed, a condition known as otitis media. The buildup of pressurized pus in the middle ear causes earache, swelling, and redness. Since the eardrum cannot vibrate properly, one has decreased hearing. Also, there is a feeling of fullness or pressure in the ear with dizziness, loss of balance, nausea, vomiting, and fever. Sometimes the eardrum ruptures and pus drains out of the ear. But more commonly, the pus and mucus remain in the middle ear due to the swollen and inflamed eustachian tube. This condition is serious because of the severe earache and hearing loss it can create. Hearing loss, especially in children, may impair learning capacity and even delay speech development. Otitis media is also serious because the infection can spread to nearby structures in the head. Thus, it is very important to recognize the symptoms of middle ear infections and to get immediate attention from your doctor. However, if it is treated promptly and effectively, hearing can almost always be restored to normal. Tips to prevent middle ear infections for infants. Appropriate management of colds, flu, and sore throats, and of hay fever and other allergies helps prevent middle ear infections. While breast or bottle feeding babies, avoid holding them in a horizontal position. A semi-inclined position prevents the milk from entering the eustachian tube and infecting the middle ear. Avoid contact of the baby with objects handled by people who have cold.
Applications in medicine. Pharmacotherapy. We can use amoxicillin and clavinate, trimethoprim, sulfamethoxazole, septine, etc. And surgery like tympanocentesis, laryngotomy with insertion of ventilating tube. Shortened antimicrobial treatment for acute otitis media. Limiting the duration of the antimicrobial treatment constitutes a potential strategy to reduce the risk of antimicrobial resistance among children with acute otitis media. Which are the pros? Clinical success occurs in more than 60% of patients, even when bacteriologic eradication is not achieved. Eventually, almost all patients improve. The cons is that many children with acute otitis media do not benefit from antimicrobial therapy, either because the illness is not of the bacterial origin or because their immune system clears the infection without use of the drug.
Acute otitis media is the most common indication for which children in the United States receive antibiotics. Current guidelines recommend a 10-day course of antibiotics for children under 2 years of age. But given the growing concern about antimicrobial resistance, Can the duration of antimicrobial treatment be shortened without changing clinical outcomes? In this study, investigators randomized 520 children 6 to 23 months old who had acute otitis media during the respiratory infection season to treatment with 10 days of amoxicillin clavulanate or to 5 days of amoxicillin clavulanate followed by 5 days of placebo for each episode, and assessed whether the reduced duration was non-inferior to the standard duration. Symptoms were tracked through the acute otitis media severity of symptoms score, which includes ear tugging, crying, irritability, difficulty sleeping, diminished activity, diminished appetite, and fever. The primary outcome was clinical failure, defined as worsening symptoms or otoscopic signs of infection, or failure to achieve resolution of symptoms and signs. Patient enrollment was stopped early when the non-inferiority endpoint was achieved. Clinical failure was seen in 34% of the children who received 5 days of antibiotics, significantly more than the 16% of children who were treated for 10 days. When both groups were combined, failure rates were found to be higher in children who were exposed to 3 or more other children for 10 or more hours per week, and higher in children with bilateral rather than unilateral infection. There was no difference between the groups in rates of recurrence, adverse events such as diarrhea or diaper dermatitis, or nasopharyngeal colonization with penicillin-resistant pathogens. The authors conclude that for acute otitis media in children 6 to 23 months old, reduced duration treatment resulted in higher rates of clinical failure without reducing adverse events or antimicrobial resistance. Full trial results are available at nejm.org.
Issues applied in Ecuador. More than 2/3 of children will experience one or more attacks of acute otitis media by the age of 3, and about half experience more than 3 episodes. More than 75% of episodes occur in children under 10 years of age.
Eight-month-old Jack is making his first visit to Boston Common Park. This stroll through the park comes just 3 weeks after his first trip to an emergency room. Carol Thornton remembers that sleepless night.
He woke up in the middle of the night pulling his ear, crying, wanting his bottle, and I couldn't console him. And I had to take him to the emergency room the next morning because he was so miserable, and he's not normally a crying baby. And the doctor looked at him and said, "No wonder he's so sad. His ear's all inflamed. He has an earache." So here he is, 8 months old, already on antibiotics.
What caused this sudden and painful attack? Jack had picked up a cold, and doctors say this led to the ear infection. The same thing happened to 16-month-old Jerome. What began as a common cold ended in a trip to the doctor. The diagnosis? Infection of the middle ear, also known as otitis media. Each year, parents in the U.S. will make about 30 million trips to the doctor's office for middle ear infections. Most of these visits are during cold and flu season, beginning in the early fall and continuing through the spring. Experts say the anatomy and physiology of young children's ears make them vulnerable to infection. The ear has 3 parts: the inner ear, the outer ear, and the middle ear. For infants and toddlers, the tube that leads from the nose to the middle ear, the eustachian tube, is different than that of an older child or an adult. It's horizontal and wider and shorter than the adults. This makes it easier for germs to travel into the middle ear. When the tube is blocked, say from the congestion of a cold, fluid that normally drains from the middle ear cannot exit. The combination of blocked fluid and the entrance of a bacteria or sometimes a virus can create an infection. It's the fluid pushing on the eardrum that causes pain. The younger a child is when he has his first ear infection, the more likely he will be to have repeated infections. Some kids are genetically at risk for more ear infections. It can run in families. Kids with allergies usually have more congestion and swelling in the nasal passages, which can lead to year-round earaches. And boys tend to get more ear infections than girls. Here are some symptoms to watch for: ear pain and tugging on the ears, irritability and crying, head shaking, especially with a fever, problems sleeping, because laying down can make ear pain feel worse. And since sucking and swallowing can worsen ear pain, a child may have trouble eating.
It's all over.
With infants, sometimes irritability may be the only clue. Even that is not always present. Healthcare providers use an instrument called an otoscope to diagnose middle ear infection. With the otoscope, a doctor can see the eardrum and determine if there is inflammation of the middle ear. A tympanometer can be used to check for the accumulation of fluid. Fluid in the middle ear or inflammation signals a problem. Dr. Jerome Klein, professor of pediatrics at Boston Medical Center, has reviewed thousands of cases. Most kids will be between 6 months and 3 years of age, and these infections can cause lasting problems.
Whenever fluid is present, there is some loss of hearing. The average loss is 25 decibels. That's the equivalent of putting a plug in your ear.
Conclusion. Among children with 6 to 23 months of age with acute otitis media, reduced duration of antimicrobial treatment resulted in less favorable outcomes than standard duration treatment. Thank you.